Thank you so much, Rohit sir, for that introduction. I'm just sharing my slide, and I have a plethora of eminent speakers over here, and I'm actually really going to the basics of nuclear extraction. But I'm sure that every ophthalmologist have to go through the phase which I am going to talk about to become the stalwarts what all you people are. Very good evening, or a rather late evening to all the speakers here. So we all we all really wish that plastic surgery would be a little easy, like we have a push of a button where we can have the cataract which can be MSC or break into all different types of quadrant. But before that, we should make sure that we have a proper excess of around 5.5 millimeter, and it should be circular so that the chances of a nuclear extraction would be much easier. We should make sure that the clear corneal incision should be perfect, and then even the hydrodissection, you can see the wave in which the nucleus is cleaved away from the cortex should always be there before we start a proper nuclear extraction. So with the NIDEC machine, which I have, these are the parameters I follow. The initial step of the nuclear extraction is the 4-quadrant technique, which we started with. So we should make sure that the length and the width of this, the cross is perfect. And once you have the depth achieved, then always go for the crack. I always tell my students that do not have 2, 3 chances. When you crack it once, it should crack. Then only you are sure that you have reached the edge of the nuclear base. So once it cracks into 4 quadrants with the Phaco's 2 setting of the NIDEC CV9000, which I have, you can see that the nuclear pieces easily come into fragmentation, and phacoemulsification is possible just by keeping the phaco probe in the center, and the followability of the nucleus is also as good as the aspiration flow rate is. The next I would say about the stop and chop technique, where only a single trench is done, and the same way you go to the depth and crack the piece. I rotate it 180 degrees to make sure that the crack is complete before I go for the smaller quadrant removal of the nuclear fragments. While cracking, make sure that your Sinsky or your dialer is just little offset of your nuclear probe and not exactly where it is holding the nucleus, or you might lose the nucleus piece from the nuclear fragments. So from the stop and chop, after this, the lens, the yellow lens from the NIDEC, which is the Actus SZ lens, which is a preloaded and goes through a 2.2 incision. It is a preloaded lens, and it is so easy where you just fill up viscoelastic in that hole which is given, and as you can see, the visco is completely filled, and being a double polymerization reaction, the chances of glistening is all definitely much lesser. So you can see how neatly the optic and the haptics are folded on each other. And I usually do a 2.8, and you can see how easily it goes. And being a hydrophobic lens, the chances of opening will be always slow, but this lens actually immediately opens up. And that is the best and big. You can see the blast finishing of the haptics as well. So I follow the 3 Ds, that is drag, depress, and dial. So drag is to make sure that it comes below the anterior lens capsule, depress it, and then dial. So this is the perfect kind of surgery when you want. So these parameters, I use it for the carousel technique as well. I use it in a high aspiration mode, where sometimes with the nuclear fragments, you can even use only the aspiration, and only for the core of the nucleus, you can give a little amount of phaco as well. So this carousel technique also works beautifully. For the hard cataract, I always use sometimes the modified stop direct chop. So I don't directly chop, make a small trench, but not as deep as it is. But then at the end, I go and trench my phaco probe. So this helps in 2 ways. One, it also reduces the amount of phaco energy you are using. And two, the only problem we have is embedding the phaco probe into the core of the nucleus, which is solved by the small crater which we create. So once you get these two halves, I'm sure that all eminent surgeons are here all over the world, and the rest of the fragmentation of the smaller nucleus is going to be very easy. Sometimes I even use this technique for harder cataract, where I'm going to use a little bit more phaco power, where I do a small tunnel with my keratome as well. So the wound integrity at the end of the surgery, even if you're using more amount of phaco energy, will be a little more much better. So this is another modified direct chop where I make a small V at the section. So this is also mainly to make sure that your phaco probe is beautifully engaged into the core and the depth of the nucleus. And once it is achieved there, I use the vertical chop and the horizontal chop for this. And then you can see how beautifully the nucleus cracks open. So once you get a single crack which extends totally, even including the posterior part of the cataract as well, other small pieces, I also use the burst mode in the Nidec machine, which usually holds the nucleus beautifully, and the amount of phaco energy you use is very less. Even under the saline, these lenses are beautifully placed. They open up beautifully, as you can see over here. And never forget the 3 Ds, which I say: drag, depress, and dial them into the bag. Just by one go, you can see it always go into the bag. And then the worst combination for any surgeon is the small pupil and the hard cataract, which is covered by most of the surgeons here. So I just wanted to say that it is not only the length, but the depth. So even if you achieve a 3 millimeter depth, and if you go even in these hard cataracts, you will easily be able to emulsify the cataract. And never go near the pupil, as they said that when you go near the pupil, the chances of iris shafting is more. And finally, we come to the direct chop, where you actually go directly into the nucleus and then you emulsify them. This is a softer kind of an intumescent cataract. So a direct chop is much preferred so that you use less amount of energy for completely removing the nuclear pieces. And then you have beautifully described subluxated cataract. So as Dr. David Chang said that, yes, even I didn't place the CTR because the chances of cortex aspiration would be difficult. But after a proper trench, I actually use 2 instruments so that I don't give too much stress on the donules. The zonular dehiscence was around 2 to 3 clock hours. So once I get that crack, which is used by 2 instruments, and not give too much of force, even without a CTR or an hook to stabilize the bag, with the parameters a bit slow, that is the bottle height comes little slow, the phaco energy we use is going to be much lesser, you will be actually able to emulsify the cataract because the core of the nucleus is got into the, and rest of the steps of the nucleus which comes out is going to be really easy. So after I remove the cortex and the epinucleus sheath, and then I definitely place the CTR before I place the lens. Yes, we always, all of us, I'm sure that all of us know this famous movie where we all wonder while swinging the
Expecto Patronum! Expecto Patronum!
These naturally cataracts here beautiful. I thank the whole team, the panelists, AIOS, NIDEC for giving me this opportunity. Thank you so much to everyone present here, sir. It's a pleasure. Thank you.